Hello, hello. Can you hear me? Good. Wonderful. I can never tell with the music whether I'm actually being heard or not. So as Angelica was just referring to, next we're going to be looking at ways that a mobile, migrating health workforce can benefit everyone, from local level, local systems, domestic health infrastructure, but also including as well the bigger global picture as well. So allow me to introduce the panelists for this session. Eleanor Knott is the co-founder and former CEO of the David Knott Foundation. Dr. Ruben Ayala is the Chief Policy and Advocacy Officer with Operation Smile. Desta Lacco is the Group Partnerships and External Affairs Director with Amref Health Africa. And Martin Masukwa is the Chief Programs and Innovation Officer for Seed Global Health. So welcome to all of you. I wanted to, and just a reminder as well, we will hopefully have some time for a Q&A, so if there are questions at the end, then raise your hand as and when I give you the warning. I want to start with really the title of the session, what do local health systems need? Ruben, I wonder if I could come to you first. What do local health systems that Operation Smile works with really need?
Hannah, how many hours do we have?
Got about 35 minutes.
There's so much we could talk about, and they're challenging every block of the health systems, around the world. But we believe that it's important to have investments, integration, and trust. And if you think about it, let's just begin with trust. Over the years, we have made decisions on health systems without that level of trust that our local leaders really deserve. And as we have changed our approaches, we have seen the benefit of actually integrating and trusting the know-how, the understanding of the context of the health workers of the countries or communities in which we hope to serve. So, and we have seen that at Operation Smile. Our evolution has been marked, and the projects we have taken have been marked by that trust. In investments, everybody's going to say investments, but we are moving or must move from the aid system into ongoing commitments and to address the root causes of the challenges that our health workers have, and including training programs, professional development opportunities, and support on an ongoing basis. That yields dividends. And then integration, so we have investments and I think I might be forgetting one. So investments, trust, and certainly integration. So you have to have the ability to bring the people from the communities to be part of the solution themselves.
Thank you. Desta, to you. Ruben was just saying that how long have we got, and I'm going to ask you a question which could probably take up the rest of the day as well. But talking about the sort of the variety of local needs across the continent of Africa, what would you say are the main things that you could pinpoint for us now, the local systems across the continent?
The local health systems.
Yeah.
So, first of all, the health delivery systems themselves are extremely weak. And so one of the big challenges in terms of maintaining a health workforce is that they are very far in between the health facilities. Most of Africa's population gets serviced in rural communities. So you can just envision that in rural communities, health facilities are not up to par. Many things missing. So you have health workers working in rural facilities where they don't have safety, where there are no equipment, where there are, lacking in so many different things. And therefore, when we talk about health workforce, for example, we are already very, very much sort of in the red. I think annually up to 70,000 health workers migrate from Africa to service foreign countries. And that leaves a huge gap for us. And why do they leave? They're not paid sufficiently. They don't have an environment that really encourages and enables them. They don't get adequate training beyond what they've already gotten. And so we have health workforce that are extremely vulnerable, not motivated, not salaried, etc. So when you think about the number, and then there are number issues also, because we don't have the data to really have a pragmatic conversation about what the need is. But what we are seeing is that those people who are leaving the continent are leaving for drivers that you and I would leave for. I mean, I can tell you for free that if you're going to pay 10 times the salary I get in a rural facility in Africa, I would come to you. And so I think we deal with a lot of challenges because we expect people to work underpaid in facilities that are not conducive for work. They don't have job sort of security in a way that they're not making more, they're not being trained more, they don't have additional training. So we find that because of the systems in place, because of the policies in place, because health workers are not encouraged to grow in the spaces they are, we see a migration from rural facilities to cities. We see a migration from cities abroad. Yeah.
And Martin, you can talk about this and reflect on what Desta's just said, I guess, from a personal and a professional perspective. Am I right in thinking you're a nurse, midwife?
I am a nurse, yeah.
Yeah, so what are your reflections then on the differences, I guess, between the local picture and the bigger picture as well, and what the need is at the local level?
Yeah. So maybe let me just add some numbers to what Dexter has mentioned. Right now, Africa has the highest burden of disease, yet it only has 3% of the health workforce. So for me, that's a very clear gap that we need to look at it very seriously. When you look at the projections, WHO projects that the shortfall will get to 6.1 million by 2030. So that's a huge gap. If you add underpay, and you are underpaid, but you are overworked because the burden is there. So like all these gaps, we really need to look at them seriously. And one of the biggest issues is when we address some of these, we don't look at addressing the whole system. So we look at implementing some of these as projects, and they're implemented in silos. Yeah. The question is, how do we make sure that we support existing country plans? Because countries do have plans. How do we make sure we are able to build on those, support them, and really capacitate these healthcare providers, not to address just the issues that we have now, but prepare them to address the challenges that we'll face in the future. Right now, we have pandemics, all these climate shocks. How do we make sure that we prepare these healthcare providers to address some of those? Thank you.
And everyone's so far has discussed this idea of the vulnerability of the workforce at the local level. Ellie, your husband, David Knott, and your colleagues, you work with local surgeons, local medics, in a completely different sort of sense of vulnerabilities, because they go into conflict zones and you're training people on the ground in trauma surgery as well. How does what you do and the services that the foundation provides really fit in with that idea of bolstering the local need as well and local health system needs?
Absolutely. So we do primarily provide surgical skills training for surgeons, anaesthetists, and OBGYNs in areas affected by conflict and catastrophe. And I think it's really important to say that the work of our foundation, most notably in Ukraine, where we've trained over 600 Ukrainian surgeons, in Moldova as well, and in northwest Syria. So there's a real recognition of the importance of well-trained, highly skilled surgeons and anaesthetists in conflict areas. But I think the example of where I've seen the most successful and innovative local health system leadership is in northwest Syria. So before the liberation last December, the northwest of Syria was essentially a quasi-state, which had a lot of local initiative and local innovation in health system creation and leadership. It was bottom-up health system governance that actually the UN and other agencies had a convening role in through the health clusters, but there was a lot of local independence and leadership. And that example of northwest Syria, I think, is one that's very inspiring for other conflict-affected settings as well, where actually vertical interventions by international organizations are not always the most helpful thing.
Thank you very much. Ruben, we've talked so much about migration and the need for a migrating health workforce as well. how do you make the argument that a mobile health workforce is actually a win-win situation, that having access to homegrown talent in a workforce is wonderful, as is having access to a foreign health workforce as well? How do you make the case that works for all?
A very important question, and it's interesting to hear my colleague talking about training in conflict settings. We don't work in conflict settings as Operation Smile, but some of the concepts that she has highlighted are replicable and certainly useful for non-conflict settings. So we could look at what are those? Support for training, support, and systems that allow for people to deliver care. So when we look at the mobilization of the health workforce, I think about this example, this moment I had as a young medical student. There was a surgeon who had done this beautiful surgical repair on a child with a cleft lip and palate. And he pulled the residents that were around him and a couple of the medical students to the side and said, you know, I wish I could tell you. And by the way, the result was beautiful. And if you were a mom or a dad, you would have celebrated just this as a real success. But he said, you know, I wish I could tell you that this is my technique. But in reality, this is a technique that I've learned with Dr. Ledesma in Mexico, Dr. Batania in Morocco, and so on and so forth, Dr. Hector in the Philippines. If I could publish this, maybe I'll become famous. But the most important thing I want you to understand is that learning from each other will open horizons for you to truly serve your people. So we have the responsibility to continue to maintain that connectivity, that web of support and exchange between providers around the world. So in the same way, you will look at doctor support in Accra supporting someone in Koforidua, or in Kigali supporting someone in Kumasi. You should be able to have the nurse from Morocco learn together with the nurse from Malawi. And if you do that, and you do that properly, think about the possibilities of actually applying their knowledge to a decentralized system in which you're offering some relief to the institutions, the tertiary institutions that have so many patients, and you're bringing care closer to the communities.
And this is a really interesting point, I think, because so much of, I think, the focus of a mobile workforce is that there are specialist skills that are needed to plug gaps in certain locations across the globe. But actually, we also need to make sure that there are general skills that are replicable across borders as well, and that there's standardization of credentials and all the rest of it. Where are just broadly at the moment, Martin, maybe you can ask this, and Desta as well, where are the biggest workforce shortfalls in a particular skill, be it nursing, midwifery, or something else? Where in the world are those biggest shortfalls at the moment in terms of a skilled workforce?
I mean, your a health
Sure.
professional. In my view, there is a shortage across the board.
Right.
Across the board. We are fortunate that we have partners like WHO AFRO, for example, that provide technical support and skills building. We ourselves, even as AMREF, have an international university that we've launched almost 7 years ago. We train 3,000, but up to 10,000 we can train. And we're not just training them in person, we're training them remotely as well. So I think across the board, from the health worker, from the community health worker, in the most rural, hard-to-reach setting, to the cadres, upper cadres, whether it's nurses, whether it's anesthetists, whether it's physicians, there's a shortage across the board. That's what WHO tells us. And I think one of the challenges for us is, you talked about conflict zones. When you have a conflict zone, that's a big challenge already. And because those conflict zones close corridors. If we had a continent in which the corridors were open and you could actually have health professionals or health workers certified to practice here, practice there, then we could at least move our health workers around. As it stands, during crisis situations such as pandemics, we've actually, even ourselves as AMREF, sent people to countries to train them. So the training is needed, I think, across the board. Would you agree?
Totally.
Yeah,
Totally.
and I think that we just need to have the investments that are necessary to make sure that all cadres of health workers are trained appropriately.
Yeah. No, yeah, just to add to what she said, so yes, the gaps are across, but it will take us ages to fill in those gaps. The question is, what is it that we can do in the short term as we're looking at the long term for us to fill those gaps? One thing that we are doing at SEED and working very closely with the Minister of Health in Zambia and in Malawi is we've helped introduce a new cadre of family medicine. So this is a specialty, but we know a family medicine physician can manage up to 70% at primary health care, like 70% of the illnesses at primary health care. So the Zambia government, in their current plan, they plan to have at least one family physician across all the districts. So what we're doing is really try to support them to train those and make sure they are deployed and they are able to manage those cases at that level. But we're also not forgetting the loop that community health workers are creating, because they are the primary contacts of healthcare. And we want to make sure that as they're being referred, they're able to meet someone who is skilled and is able to manage some of those cases. Because as we're looking at the gaps, but we should also be looking at what are the key drivers of mortality across these countries and how are we preparing the health workforce to address those.
Yeah.
Can I just add one more?
Please do, yeah.
I think also very important is that countries in Africa right now are very much constrained across the board. They're constrained because of shrinking ODA. I mean, you know, just the other day, I think I mentioned this to you earlier, when you think about the US government coming out and saying for H-1B visas, there's going to be a $100,000 per head fee for an H-1B visa, and America is saying that, imagine now other African countries that don't have that means even to be able to attract health workforce to come and work with us. So I think across the board, between ODA shrinking, between government constraints to fund health in general, governments, most African governments are busy servicing foreign loans, right? So we have so many constraints against us that to really free up dollars to say, we will invest in our health systems. It's not that the plan is not there. Every country has a health plan, for crying out loud. Every country has a health plan. The question is, do they have the financing to roll out the health plan so that it meets the need of that country? And the reality is, they are extremely constrained.
When you say every country has a health plan, and I believe you, I'm sure they do, but I suppose countries that are wrapped up in civil war or in conflict in some way, they might not have a health plan as certainly a priority in the here and now. Say, for example, Syria, where I know you worked so extensively, Ellie. Is it frustrating to you when you hear about the talk about like specialized skills going, you know, needing to migrate here, there, and everywhere, when so much of your work with the foundation is about general, just like whatever comes through in whatever the operating theater outfit might look like, you need to be able to have trained medics trained surgeons who can just do something, whether they're an anaesthetist or whether they're in whatever their specialist area is. How frustrating is it for you, if at all, that we're talking about the sort of the specialisms, and how much of a push would you like there to be for general knowledge, just like the general share of standardized health practices?
It's a good question, and I think a key thing is that you have to understand that the more you talk about specialization, the more that can require a lot of specialist equipment, knowledge, resources, which, as we've established, are not available. They are just not. And I think that's the key thing that we do with the foundation, is that we're teaching doctors also decision-making strategies. So you might have the knowledge to be able to do a particular operation, but if it takes all of the minimal resources of, say, blood that you have, then it's probably not wise to do it if you've got an A&E department full of 30 others needing urgent treatment. And I think as well, just to say, you know, the shortages of skills and of personnel are across the board. As a surgeon, you could do a beautiful operation, but then if you don't have the follow-up, if you don't have the post-operative care, if you don't have IV antibiotics, if you don't have rehabilitation, that operation is essentially pointless because it will fail. So it's all about having to make the right decision with the resource constraints and also the skills that you have to be able to make those choices and those decisions.
And do you only work on the sort of like the short-term immediate need, or is there also a plan in place, say with the Syrian government as it is now, to say, what are the local health needs ongoing, as in, so it's largely not a conflict zone anymore. So do you work with them to see what the local health needs are just in terms of ongoing care rather than just trauma care?
Yeah, very much so. So I've been in Syria twice since December of last year, and because previously we'd just worked in the northwest. And it was quite an eye-opener being in these hospitals in Damascus, in the capital of Syria, which I'd anticipated would be of a higher standard than in the northwest, and not at all. And it's an example of how, I'm afraid, politics, it's important we're doing this during UNGA week, politics is absolutely central to everything, because what hollowed out the health system in Syria in particular was sanctions and was conflict, but was also corruption. And these things do exist in health systems in many different states in the world. So we've got to kind of acknowledge them, that they are real and they are factors.
Yeah, thank you. I want to talk about safety standards and the standardization of health safety in general as well. Ruben, I wonder if I can ask you about this. How do we ensure that safety standards are followed by what we hope would be a highly mobile health workforce?
So I want to maybe follow up because this was a really important conversation. You're talking about conflict and crisis, yes, right? And now we look at a different environment and we start realizing that 5 billion people lack access to safe surgical care around the world. So when you're compelled with something like that to act, you think about it as a crisis. So if we look at it as a crisis that is impacting all of us, then we start looking into investments. If you want to address the issue of quality and safety, you have to open the gateways towards knowledge. And you have to look for the collaboration. And you have to professionalize the way you open those opportunities. You have to go from crisis to a building mode. So we're also trying to figure out a way today to take care of a child today while trying to build systems for the future. And sometimes the needs are so vast that you just have to pick up something that is very specific. So we committed to training 100 teams in 100 hospitals and supporting with the right supplies and infrastructure and connect that with a national health strategy to prove that if we indeed do what we need to do for health workers around the world, often that bidirectional exchange in knowledge, they will commit to taking care of their communities. It's obvious. People don't necessarily want to live their own. So if you want to talk about standards, it starts by giving people the opportunities to have the knowledge. And then you put the systems in place. So people, places, pathways, and policies is what we say sometimes at Operation Smile. You support the people, you give them a place to work, you give the pathways for patients to come to them, and the policies working together with ministries of health and experts for standards.
So when you say knowledge, you're also talking about like training and education, and it all comes from those foundations, I guess.
Absolutely.
Martin, from the primary care perspective then as well, how do you build out those training programs that are actually could have impact over the next 5, 10, 15, 20 years?
Sure. So one of the things that we do is in every country that we work in, we are invited by the host government. They know their problems better than we do. At times, they pitch to us some things that we are not even competent to. And we are also very honest to say, no, this we can't do. But to answer your question, and I'll give an example of introduction of emergency medicine in Uganda. We worked with the government to introduce the first cadre of emergency physicians in Uganda, just after COVID. What we did was we had to get faculty from the US because there was no faculty. So we brought 2 faculty members at Mbarara University. They started training the first group of emergency physicians. The course is 4 years. After the 4 years, we continued to provide that. Right now, as I speak, we have 3 members of the faculty who are managing now the Mbarara University emergency medicine, who were trained by SEED, but now we have a head of department who was trained by SEED, but now they are managing it. Our plan is obviously to slowly transition out of that while continuing to build different other specialties. So that's one area. The 3 that are there, they've been hired and are being paid by the Ugandan government. The government is still very ambitious in terms of numbers, so what we've done is we've introduced the same at Makerere. The transition looks different because Makerere and Mbarara are different as well. Again, as you mentioned, we are building the ship as we sail. We are learning as we go. we keep working with them just to make sure that we are not imposing, we're acting as a catalyst, and they are in the driving seat, and we're providing the support that they need.
Thank you. Desta, what advice or what would you say to policymakers who are perhaps listening to this conversation about how to actually build that workforce that's needed across Africa? What are the things that they should keep in mind when you're dealing with, when often it's policymakers in high-income countries who are talking about things that are going to have impact in lower middle-income settings?
I think the first thing is we need more data. You know, you can't make decisions. Yeah, you can't make decisions unless you have actual numbers. You need to understand what the health workforce shortage really looks like, what the need really is. You have to know where your gaps are in order for you to actually have policy that is relevant or that makes sense, right? So that's the first thing.
So how do you get that data?
You have to do it at community level. You start from the community level and you have to get aggregate data, you know, what's needed, who's there to fill it, how many facilities you have. If you think about most of the facilities most of healthcare in Africa is delivered in rural areas. About 14% of those rural areas are not electrified. So you see what Eleanor said earlier about, you know, you need so many things. It's not just an OR, and you need follow-up care. You need all of those things, post-operative care. About, I would say 15% of health facilities in rural areas are not electrified at all. So you cannot even keep medicine safe. Right? So there are so many conditions that health workers are facing, and you need data. You need to understand what the health workforce gap is, what the actual gap is. You need to understand how many are moving up in the cadre. You need to understand if there are opportunities for growth within sector, within whatever specialty there are. People are moving directly from rural communities abroad. The opportunities are there, and I think that unless we understand what that loss means, what does that gap mean in terms of even, you know, humans and how we deliver care? And I think that's the first thing, is understanding your data, collecting and understanding your data.
And then I guess it's not just about people then leaving their home country and going overseas or going elsewhere, but it's also, how do you recruit people? How do you actually encourage recruitment now? We were talking about it in the last couple of sessions.
So you have to make sure, let me tell you, there are people who finish nursing school and cannot get a job. Yeah. It's not like, you know, just because you're trained, you're going to get the job. The governments have to prioritize it. They have to be able to pay people to come and work. People are not going to work for free. If you look at an average nurse salary in Kenya, and Kenya has, you know, per capita spending on health is about $50, maybe, which is really good compared to other countries. A nurse in Kenya might be paid $6,000 to, you know, if she's highly, highly qualified, $10,000 a year. Compare it with what the US pays, on average $89,000, $90,000 per year. So we are not compensating our health workers sufficiently to begin with, but we know that. Yeah, we know that. But there's so many things that you do. And in order for you to make the right decisions, you need the data, first of all.
Go ahead, Ruben.
I would just add that once you have that information, and some of it is available, some of it is easy to collect, you can actually enact programs. So as an example, Rwanda had the first national surgical plan, and they knew they had about one surgeon obstetrician or anesthesiologist per 100,000 population. You should have 20. So they put a plan in place, and by the 5th year, they were closer to 4. Ghana is at 6 per 100,000 population. They need to get to 20. They've put together, we've been very privileged to work with the government of Ghana to put together a plan, and they're targeting at least reaching 80% of that target within the next 5 years. Rwanda now has a 4x4 strategy in which they're pushing to quadruple the workforce within 4 years. It's an admirable goal. And then you have to, once you have those targets, you work together, you look for the solutions, and then you start making impacts. So at Operation Smile, we know that we're not going to be able to train at the average of 20 per 100,000, but we can surely make a dent and work together to create residency training programs and support nursing training and support anesthesia training and partner with professional societies, academias, Ministry of Health, private sector, because that starts moving us towards the right and on the right path and towards the right goal.
And Ellie, I guess that a lot of in conflict zones, a lot of people leave for obvious reasons, and the hope then is that they go back to their home country once it's safe for them to do so as well, and that they contribute to the local health system and in that way as well. And presumably that's something that you would thoroughly encourage through the foundation and your work, is that you can not only upskill people in general trauma surgery, but also that you can ask people who have left their home country, when they go back, to also take those skills that you've trained them with, so they can train other people as well, whether it's the primary care or whether it's in trauma surgery or anything else as well.
Yeah, hugely. I mean, it's very important, I think we've got a real problem at the moment in that the global north, if you want to use that term, has just become such a draw and such a magnet. And it's depleting and harming the rest of the world by having this magnet effect. And I feel it very strongly, actually. And the WHO kind of code of conduct says that you must not do this. You must not go around various nations in the world basically scooping out the healthcare workers that you need to plug the gaps in your system. I think it's morally wrong. And there needs to be more investment. It's why it's so counterproductive that the UK, we've gone from 0.7% spent on ODA to 0.5 to now 0.3. And okay, if you want to wrap that into, I think it's not even just aid, it's actually stabilization activities as well. Because by investing in fragile, conflict-affected, and just low-resource nations, you're cutting down this desire for everybody to just leave where they are, and actually investing in a proper, decent future where people have something to look forward to. And I think certainly, there's been some really interesting discussions, eye-opening discussions about foreign debt write-off as well, and how, there's a certain kind of limit on the number of public sector workers you can hire under some international debt agreements. That needs to be looked at as well, especially if we are taking aid that nations have learnt to rely on.
Thank you. And Martin, I know you were nodding along about the recruitment in particular and the need how do we recruit more health professionals? Desta had been commenting on it as well, but I saw you nodding along, so I didn't know if you wanted to add to that.
Yeah, so I was nodding for two reasons. The first one is there's that drain, but we're draining from these poor countries. There's a huge investment that goes into training these people. One of the things that the Africa CDC is spearheading and working on is the Health Workforce Compact, because these shifts are not just from Africa to the West. There are also shifts that are happening within Africa. The question is, how do we make sure that the source country is compensated, maybe to train more? Because some gaps, like in Uganda, for instance, you have medical doctors who are in the streets looking for a job. Yet there are gaps within the ministry. Recently, actually, a couple of months ago, WHO did a needs assessment. What they found was, one, the need is there, the supply is there, but the demand is not there from the government. A couple of years ago, they froze the recruitment process. Now they've unfrozen it, but they haven't followed that with funding to support that recruitment. So the question is, how do we really work with these governments to support them, to make sure that these are prioritized, so not just the recruitment, but also the absorption and the support that these healthcare providers need. Thank you.
Thank you. Desta?
I think it comes down to political will also. You talked about Rwanda and Ghana. Those governments are committed. They're committed, 100% political will there. If you drop anything in Rwanda, it will happen because there is political will. But there are many countries where that's not the case. And I think to your thing about there are physicians and there are nurses who don't have a job, it's not because there is no need. There is no budget. and there's no commitment.
There's political will and
allocate.
funding.
Exactly. So you can decide where you're going to allocate your limited budget. So that's where the challenge also is.
Questions from the floor. If you do have a question, please just raise your hand, and then someone, yes, in the front, sort of second row back here, I believe someone will have a microphone for you. Yes, there we go. If you wouldn't mind just saying your name and organisation, please, be grateful.
Hi, everyone. My name is Ashvina. I'm originally from Mauritius. So in Africa, it's a tiny island that probably many of you haven't heard of. And I want to speak to the how can we do things differently when we talk about internal migration within African continent? Because instead of saying, we have the same problem that used to be between Africa and the West, is there a new model of cooperation where regionally or within the continent, countries can actually collaborate, partner, support each other? So if one country is actually better at training in a specific area, how can we train each other and collaborate? Is this something that you see possible? Because I know politically it might be maybe difficult. Is there a role for the African Union in there? Or what are the chances of that happening? Thank you.
Thank you. Martin or Dester?
I think I'd say the following. When we see pandemics, I mentioned earlier that, for example, AFRO, WHO AFRO, even AMREF as an organization, we have sent our teams. And we are a little fortunate because we have AMREF flying doctors as well. So we actually have carriers that we can take over from one part of Africa to another. So we do provide support and training. That is possible. I think what you may be talking about is how do we get doctors or nurses or other health providers across borders where the need is. And I think that also comes back to politics and coordination among countries, across countries, and looking at how do we align our policies, accreditation of health workers, how do you make equal, right? And I think that has to do with political will as well. I mean, Mauritius is a small place, but that doesn't mean it doesn't need people, right? But if we can train health workers in Mauritius and have them work in Kenya or Ethiopia or, Senegal or Ghana, why not? But I think there needs to be standardization of health worker credentials and, that kind of thing. Are we there yet? No. Do I think it's a great idea? I actually do. I mean, if we have conflict-affected places, we did an interview with a doctor from DRC, and in the Sahel also, same problem. And there was no blood. He was doing a procedure and there was no blood. And he actually had to take blood from himself, the treating physician surgeon. So we have so many gaps. But if we were to align and have, standards cross-border, sure, I think we could share physicians and other specialists.
Yeah, just a quick addition. The Africa CDC, under the leadership of the African Union, they are working on an Africa Health Workforce Compact, and it's addressing just that. So it's actually in the finalization stage. And they're hoping to present at the next African Union. But, we know as well, these documents are developed. The question is exactly so.
How is it going to be implemented?
Exactly.
Yeah.
But this is being done, and it's addressing most of the issues that you raised. Yeah.
Thank you. Ruben, you wanted...
Operations Mal doesn't have the privilege of working in Mauritius. If we did, I will be right there in an instant. But obviously, we can talk about investments in GDP in health across nations. Most of the almost 40 countries that we work on, where we work, are investing less than 9%, which is the average of GDP you should be investing in health. But they're trying. They're trying, really trying. I see some countries, so in Ghana, and the government of Ghana is giving the health workers in remote regions a pay raise of about 20% because they want to keep them. So these are some of the bigger macro conditions, but there are some real lights and examples of opportunity. We partner with COSEXA, the College of Surgeons in Central Africa, and COSEXA has been able to create a system of training and collaboration that is allowing surgeons to remain in their countries, 93% retention rate. By the way, don't get me started on AMREF, who do an amazing job, and it really is a privilege to be with my co-panelists here. Another example, the Southern African Development Community's Technical Expert Working Group is supporting countries, including Mauritius, and we're part of the effort, to figure out a way to advance surgical systems, surgical plans, work with governments. So yes, we still have a problem, but I think we should not dismay. There are real lights of opportunity that we should pursue as templates for success that we can't let go.
Thank you. Any further questions from the floor? What? Yes, please. Sorry, I've been having my back slightly to you.
That's fine. Wonderful conversation. Thank you so much. My name is Manish Kohli. I'm with the Pole Alliance for Digital Health and Equity, and we actually work with one of the partners that is funded by Operation Smile. So thank you. Agree with politics can be a barrier. It often is. I think there is an opportunity in terms of workforce development. But what we see in the front lines, there's tremendous friction for the people who actually want to work there. I'll give you an example of the hospital where the surgeon who flies into the hospital to provide cleft lip surgery for kids, the nurse holds out a smartphone saying, in my home, I live in the 21st century. But when I come to work, I'm back in the 19th century. What are the barriers for us to really begin to help transform but leapfrog Africa? And I think this is where we need to also begin to look at what are the opportunities to reduce the friction. How do we optimize the donations that are given in terms of equipment? 70% is going to landfills. So I also think we as a business should look at efficiency improvement. And I think investments do need to go into that. But thank you for supporting our partner.
Thank you. I don't know if there was a question in there, but a comment. Thank you. And a call to action. Okay. Thank you very much. Any further questions?
I just want to say something to what he said.
Absolutely.
I think, if we think about the African continent, not all of them, but African continent, the mean age in Africa is 19. And so if you think about a continent that is so young, digital transformation will be essential for us to be able to deliver at least health information at the last mile.
If I may, I can't contain myself because there's so many examples of innovation. I'm actually here with a colleague from Rwanda, and the first time I went to Rwanda, I was talking to one of the leaders and said, you know, if you need blood for surgery, how do you get it? This ambulance ride is going to take a couple of hours. He's like, oh, we get it by drone. And now Zipline is worth, I don't know, billions out here. But so those innovations are already out there. We have been privileged to use AI systems to look at the quality and safety. So now, instead of having to go through pictures of the pictures, systems are able to give you a score whether you did a really good job with surgery. So you make a really great point that, again, we get flooded with all the challenges, but there's so many opportunities. And countries, especially such as Rwanda and others in sub-Saharan Africa, are just as they leapfrog the communication system, that we can do that also in access through health. And if we do that to the most remote communities, what an investment it could be in development, in giving people a chance, access to health as a human right. If we don't do that, then we should be asking ourselves, as Paul Farmer did, who's human enough to get access to it? We have a chance. So great points.
Thank you very much. That is all we have time for this particular session. Please, everyone, join me in thanking this wonderful panel. Ellie, Ruben, Desta, Martin, thank you very much indeed.